All surgeons. First of all, I am delighted to welcome you all to today's session of Ask Your Mentor, which enlightens the younger surgeons. Before the presentation, I am proud and honored to welcome Dr. Srivalli Natarajan, who is your mentor for the session, Cysts and Benign Tumours. Dr. Srivalli Natarajan is Dean, Professor and HOD, Department of OMFS, MGM Dental College and Hospital, Navi Mumbai. She has completed her BDS, MDS and PG Diploma in Clinical Research, past Executive Committee member of MSc AOMSI, Chief Editor in Journal of Contemporary Dentistry, Associate Editor, Journal of Clinical Dentistry, has several national and international level publications, organized several national and international conferences, PG and PhD guide. She has 20 years of teaching experience and has held various posts of IQAC, Coordinator and Member Secretary of Institutional Ethics Committee, and she is a recipient of Colgate Gold Medal and Koka Anjan Endowment Award. We welcome you, ma'am, to this session.
Yeah, thank you, Dr. Triveni. A very good evening to the members of the Tamil Nadu chapter, Tamil Nadu and Puducherry chapter of AOMSI. So my thanks to all the organizers of this session, particularly Dr. Elvinil and Dr. Kalpa, Dr. Triveni, who's going to be the moderator for this session, for having given me this opportunity, and of course the wonderful students whom I see have joined in great numbers. Yeah, so I think Dr. Triveni, you would...
Yes, it is a 30-minute session, ma'am. Without further ado, let's jump into today's topic, cyst and benign tumors. Over to you, ma'am.
Okay. So I think the organizers have already done a great job. I think Google Forms have been circulated and some questions have been invited from the students.
Yes, ma'am. So the first question of the day would be, what may be the cause of recurrence in giant cell lesions?
So when you talk about, let us take up the central giant cell lesions of the jaws to be particular. So I think from what I see, there are a lot of students, and we are going to look at it from an exam angle, how we are going to handle such questions. So when such a question is going to be asked, I think my advice to students would be to make a mind map of how you are going to approach this particular question. So first of all, you will have to broadly define, because even the definition of the central giant cell lesions of the jaws have undergone a lot of change over the years. Need to go through the historical perspective on that, the basic biological behavior, because before we answer specifically as to about the factors which influence recurrence and treatment outcomes, I think we need to understand the biological, or you need to definitely write about the basic biological behavior and etiopathogenesis. So definition, of course, I'm not going to go through each of it in detail, but I'll be giving you the highlights, because that's what we can present to you in about 30 minutes. So it's an uncommon lesion. Histopathologically, it has been classified as a benign entity, but it can be locally aggressive and a destructive osteolytic lesion occurring in the craniofacial region. So these are the key words which have been used in the definition, which can be solitary, multilocular radiolucency with scalloped margins, showing a honeycomb or a soap bubble appearance. So when you're describing, it's a good idea to start your introduction by giving a definition and describing some salient characteristics. And what's important is that these lesions have been observed in younger patients, mostly less than 30 years, and in fact 80% in less than 20 years. And the WHO has gone on to define. So when the WHO gives a definition, it's better to write down that definition in your paper. It's defined as a localized, benign, but sometimes aggressive osteolytic proliferation. The word aggressive needs to come in your answer. You'll see the relevance a little later. Consisting of fibrous tissue with hemorrhage and hemosiderin deposits, presence of osteoclasts like giant cells and reactive bone. So in fact, at some point of time, I said historical perspective, they were even calling it as a reparative granuloma because they thought in less than 20 years of age, these lesions arise because there is resorption of deciduous teeth, and these are reactive lesions to that phenomenon, and probably they are self-healing and disappear. So, but now over the years, what is the dictum as it stands today, as we understand? Now we are very clear that they are not self-resolving. They are non-reparative. In fact, the word reparative is right now out of the dictionary, and they continue to destroy and grow if they are not treated. So that's very clear that you are not going to just push it under the carpet and not treat it. You need to treat it. Okay, yes. If it is it an isolated lesion in the jaws, or are there similar lesions elsewhere in the long bones? Again, no great clarity on that, but there are lesions in the long bones which are called giant cell tumors, which are equally aggressive. Whether these both are same, whether they are overlapping or they are different, still the relationship is not clear. So when I said you need to understand the basic biological behavior before you come on to what are the factors, clearly they have found, I said mark the word aggressive. So you need to emphasize in your answer that there can be two types of clinical courses taken by these lesions. They can either be non-aggressive lesions, which are slow growing and asymptomatic, or you can have a group of giant cell lesions which are aggressive. So when I say aggressive, what are the clinical features that you have to underline? They will mostly occur in younger patients. They will be painful. They grow rapidly. So you need to take a history, because a similar case might come to you as a short case or a long case as well. So you need to have this pertinent history on the rate of growth or progress. So rapidly growing lesions, which are overall, when you see a radiograph, as I see here, if it is of a pretty large size, that's over about 4 millimeters or so, causing cortical perforation, as you see in this axial section of scan, and also causing root resorption and displacement. That is what is defined as an aggressive lesion. So these features will have to be brought out in your answer, because these kind of aggressive lesions, if they have been treated only by enucleation alone, stand a chance of recurrence of 15 to 20%. So that means your diagnosis forms the baseline for identifying these lesions. A quick look at what you can write for the etiopathogens is still, there is no one-stop answer. They have called it an inflammatory lesion. It could be a tumor, an endocrine lesion, or a vascular mishap. But again, the point I would like to make here in your answer is you have to clearly rule out Brown's tumor of hyperparathyroidism. Because if it is a Brown's tumor which has a similar picture with overlapping features, and you are going to treat it with enucleation without identifying the primary problem, probably you are looking at recurrence. It's going to come back again. So you need to highlight the fact that you need to rule out Brown's tumor by doing some lab investigations, as I wrote there. So factors that actually influence the outcome of treatment and whether recurrence occurs or not is clearly clinical features. That's a highlight. You need to see the location of the lesion. Maxillary lesions are more recurrent. Size of the lesion, if it's more than 4 millimeters, it's probably an aggressive lesion. Aggressiveness based on the clinical course, as I said, rapid progress, resorption, cortical perforation, and young patients. These are all, you're going to keep your fingers crossed. And when you do a biopsy or when you see the histopathology, what you're going to look look at increased number of giant cells, increased mitotic activity within these giant cells, larger giant cells covering a much larger surface area. These are all again factors pointing towards aggressiveness and higher chances of recurrence. So clinical parameters are important. Histopathological features, you need to look for these features specifically, and you have to identify these lesions which are going to be troublesome. So there is that set which is aggressive clinically with those specific histopathological markers. Those are the ones which you cannot treat only by curettage or enucleation, which you have to pair up with the peripheral ostectomy, so that you run your vulcanite burr to remove an additional millimeter of bone around, and also use a chemical fixative in the form of a modified cornoise, so that further 1.5 millimeters of bone is covered. So you'd move this extra step in order to ensure that you don't have recurrence in these lesions. So to put it in a nutshell, clinical activity of the lesion. Aggressive lesions, younger patients, larger size, and on histopathology, when you see a larger surface area presenting with giant cells, with increased mitotic activity, much larger giant cells, yes, these are all the factors that have to figure in your answer as probably lesions with higher probability of recurrence if you don't pair up your conservative surgical management with some adjuvant measures. Yeah, so I suppose these are the references which describes these factors well after long periods of observation in a sizable number of cases spread over the aggressive and non-aggressive groups.
That was an aggressive, exhaustive explanation for such a confusing topic, ma'am. Moving on to our second question, what is the role of the non-surgical management of giant cell lesions of the jaw?
Yeah. So when you say non-surgical, so obviously when you're asking such a question, you are very clear that surgery alone is not going to do the job. So there is some non-surgical element which is going to be involved. So again, as you can see, I've already explained in the previous answer that we are not clear about the etiology. We still think there are still articles saying that it could be a reactive lesion. It could be an inflammatory lesion. There is a hormonal influence. It could be self-healing, even though we, as on today, the proposition is it is not self-healing and it is progressive, and probably it could also be a sister of a benign tumor in the long bones. So there is still confusion around etiopathogenesis of these lesions. So again, you have the aggressive and the non-aggressive variants. So that is why, as Dr. Triveni also rightly said, they are still difficult conditions, which we are still not confident. So we have still been looking for alternative therapy. So when you don't know what is the cause, normally we say that the treatment should be directed towards the cause. So when you're not too sure which is the cause for sure, then again, you are kind of mixing and matching with your treatment. So what has been doing the rounds in literature are intralesional steroids, alpha interferon, and calcitonin injection. So this will also have to figure in any of your answers on central giant cell lesions. So you will ask why intralesional steroids. So it's been first. So you will have to always give a little bit of historical background. So we've been working since 1988. They have tried 50-50 mixture of 2% lidocaine with 1 in 1 lakh adrenaline with triamcin alone, 2 ml per centimeter. So they say that you have to measure the overall size and then decide how much you want to give. 2 ml per centimeter of lesion, and as you measure on an OPG, you can repeat 6 times at weekly intervals, has been the regime which has been suspected, which has been propagated. What is the evidence of success? When you talk about so many types of treatment which has been tried, obviously when you're trying more and more treatment, that means nothing is 100% effective. That is one thing you can be very clear. So you have to point out some literature evidence on what has been the evidence of success. Intralesional steroids, they have played around 50% has been the success rate. They have shown good results in unilocular lesions because they are able to reach all around, not so good in multilocular lesions. Why did they think that steroids will work? Probably because we have already said inflammation could be a cause of this lesion. So that's why steroids have been tried, and these lesions have shown histopathological similarity to entities like sarcoidosis, where steroids have done well. So that's why they've tried steroids. Second one is, of course, calcitonin. I already said this has always been spoken of along with Brown's tumor. So parath-hormone-like hormones might be there in the body, which is actually being the inciting cause for such lesions. We've always suspected that, and calcitonin is a natural antagonist to parath hormone. So they have tried calcitonin, subcutaneous injection, 100 units daily. You will have to monitor these lesions radiographically, looking for resolution, which have been reported up to 6 to 9 months, and treatment has been continued for 24 months. And when there is no further resolution, you will have to stop. The other one which has been tried is, of course, alpha interferon. That's because we said that the etiology could be a vascular mishap. So this is an anti-angiogenic agent because we can see a lot of vascularity in these lesions with areas of hemorrhage and hemosiderin deposits. So they have tried this anti-angiogenic agent alone or as an adjunct to enucleation, 3 million units per square meter. 24 to 48 hours post-op, they have started, and they have to follow up, and they have tried this till bone fill is observed on the radiographs. And denosumab. Now, in the further questions, we will see what are the factors which are bringing out so much of resorption in these aggressive lesions. And one of the molecular factors is rank L, which is found on the osteoclast. So denosumab is again a drug which inhibits we all know that osteoclasts are cells which bring about osteolysis or resorption of bone. So anything which inhibits osteoclastogenesis will reduce the resorption of bone or probably inhibit the aggressiveness of these lesions. Denosumab is one such drug. Subcutaneous dose 60 milligrams per month has been tried. Again, no aggregate data on this. You can only mention it that there is evidence on this, but nothing very, very conclusive. It has its own set of side effects. So these are the references. So if you have to answer this question, it's a good idea to mention the names of these drugs and what little we have gathered out of the literature on the performance of these drugs in terms of outcome. And you can give your references there.
Thank you, ma'am. Just a doubt over here. Is there all we talked about is how to stop creating inhibitors for osteoclastic activity. Is there anything that can stimulate the osteoblastic activity for the bone that has already been resolved there in these cases?
See, osteoblastic activity, they have tried bone grafting and all these things, trying a scaffold inside, which is going to enhance. But the point of insisting on osteoclastic activity is that they have found that in most of these aggressive variants, including the ameloblastoma like tumors, there are some genetic mutations which are leading to these cells secreting a lot of these factors which are going to promote osteoclasis. So the osteolysis or the activity of osteoclasts. So basically, even in the osteoclasts are not abnormal cells. There is always a balance between osteoblasts and osteoclasts, even as a normal process of bone remodeling. But when a tumor secretes factors which are going to stimulate more and more osteoclasts, that is when a problem arises, because the tip between osteoblasts and osteoclasts. So when you have a lot of osteoclastic activity, trying to promote osteoblasts is not the point. Osteoblasts are still no. What you have to arrest is this tumor-induced excessive osteoclastic activity. So that is why the focus and treatment is there is an excess of osteoclastic activity. There is no deficiency of osteoblastic activity. So rather than trying to keep pace with this enhanced or exaggerated osteoclastic activity, it is better to arrest that abnormal osteoclastic activity, which we'll understand in the slides to come. What exactly is the problem in these aggressive tumors?
Thank you, ma'am. Moving on to our next question. Recent classification of benign odontogenic tumors.
Yeah, so I think time and again, these tumor classifications have been revised. Again, we'll have to definitely move on to the WHO classification. After 2017 to 2022 gave an update. The only additions which we saw in the 2022 version was the addition of adenoid ameloblastoma in the classification amongst the tumors, and surgical ciliated cyst of the jaws was a new entry as far as the cystic lesions are there. And of course, this particular classification in 2022 also gave clear-cut diagnostic criteria along with it, and the molecular advances or the molecular landscape. So that is important. So when these students are trying to address, I think that's the level at which, even though we are all oral surgeons, I think we need to understand the pathogenesis if you are talking about treatment outcomes. So it is at a molecular level that these tumors and cysts are actually discussed today. So even as a surgeon, it is important. So this is the broad layout of the classification. The reference is given. So it has been classified as benign epithelial, mixed, mesenchymal. Traditionally, it has been described this way. So I've already circled the two new entries into this classification. But what again this classification has not done is, again, there is no clarity on the variants of unicystic ameloblastoma. If you see this classification does not address the different histopathological variants of ameloblastoma. They have grouped everything under what is called conventional ameloblastoma. All the solid or multicystic have been put under conventional ameloblastoma. And the only other variant they saw other than the extra osseous is, of course, the unicystic ameloblastoma. So when you talk about the unicystic, again, this particular classification has not addressed the different variants within the unicystic, because within this you have intraluminal, luminal, and mural. So all of them are classified under the umbrella term unicystic ameloblastoma. All the three of them have shown this BRAF-PV600E mutation, which has been found in all the three types. But however, students have to highlight that the treatment selection will be different in these three. So that is the clinical significance of this. Conventional ameloblastomas have also shown the same genetic mutation. And when we talk about the recent advances in the management of ameloblastoma, we'll talk about this targeted gene therapy and all these things. But however, one other classification which is given in the textbook Marks and Stern is this, which is not again elaborated in the WHO classification, but it's a good idea to understand and talk about this, particularly of the unicystic ameloblastomas. So they have classified it as ameloblastoma in situ, under which you have got two variants, that is the mural and the intraluminal. Mural, as you can see, the ameloblastoma develops in the epithelial lining, but doesn't spread into the underlying stroma. It is restricted to the lining. And the intraluminal, where it has arisen in the lining and it is spreading into the lumen of the cyst. Both of these are amenable to enucleation because you can see that the stroma is intact. The connective tissue wall is still intact and the bone is very much intact, so they can be treated by enucleation. Then they use the word microinvasive, where you see that there is a spillover of the cells into the surrounding connective tissue wall. So this is intramural, but however, the entire thickness of the wall is still not involved. So this can also maybe treated by enucleation. But when you look at this, you see that the entire connective tissue wall is involved. So that is called transmural. Transmural ameloblastomas are more aggressive. You can see more invasion. So you cannot treat them by enucleation. You probably have to consider a resection, just like how you would go for a solid multicystic type. And of course, the invasive variant, where it has gone well beyond the connective tissue wall into the surrounding bone, very similar to the solid or multicystic, where you have to go for a resection. So the point of me putting the clinical significance of me discussing the different variants of unicystic is that once you declare it as a unicystic, you cannot just be laid back in your treatment approach. You can see that you have invasive variants within the unicystic. So be careful in selecting your treatment option, because otherwise you will land up with a recurrence. So invasive ameloblastomas with a unilocular radiographic appearance, which may be just diagnosed as a unicystic ameloblastoma, again may result in under-treatment. So the good idea is to go through the histopathological lining. And again, if I say doing only an incisional biopsy and just declaring it as a particular variant of unicystic is not right. You have to see the entire lining to see, because it may be micro-invasive in one part and more invasive in another part of the lining. So your treatment option will have to be selected only after you see the entire lining of an unicystic ameloblastoma. So it's a good idea to write the clinical relevance of this classification when you are addressing this particular question. Yeah, probably the WHO will also throw light of it in the next whatever modification it does.
Yes, ma'am. This new term in the classification, what is the surgical ciliated cyst, ma'am? Any clinical significance for it? They've added this term, you've said, ma'am.
No, I don't think there is any particular surgical significance added to it. It has always been there, but I think they have just included in the classification in this particular recent modification which they have come up, update which they have come up with.
Moving on to the next question. What are the bone resorbing factors in the cyst?
Yeah, so I think whether it is a cyst or an ameloblastoma. So as I said, we have to, the resorption is more, particularly when you talk about aggressive lesions, they are going to spread only if the surrounding bone yields. So they are going to find their way into the surrounding bone by releasing factors which are going to resorb bone. So when you're talking about novel approaches to treatment, you have to target, or when you're talking about targeted therapies, you have to understand these genetic mutations and you have to understand these bone resorbing factors. I think when students have asked this question, naturally something has stimulated their interest to know what is it that is causing so much of destruction in the bone when you see what you see in the case of an ameloblastoma or an aggressive giant cell or an OKC kind of lesion where extensive amount of mandible is destroyed when you see. So there are factors leading to bone resorption. and invasion. So that is what we are going to highlight in the answer. And the significance is, if you target your therapy, if you are able to identify these factors, understand their role, and target your therapy against them, you will be able to control the tumor development and progression. So when you can say that they are the molecular signatures of these cysts, intraosseous odontogenic cysts and tumors. So when you say molecular signatures, they could be factors which affect bone remodeling. They could be digestive proteinases like the matrix metalloproteinases, which actually cause dissolution of collagen 1. Collagen is the fibrous component which is there in the surrounding bone or connective tissue. So anything which digests the collagen is going to help give a free hand for the tumors to progress. We have to understand genetic mutations which have been there and the role of stromal components in ameloblastoma. So just for the benefit, because I think molecular level of understanding is a little complex because we have not done it in our basic sciences. So I would just like to play a small video.
Rank OPG signaling pathway.
These are the terms which are going to come, which you have to mention in your answer.
So to begin, RANKL, or
so this is an acronym, RANKL. So it is
actually stands for receptor activator of nuclear factor kappa B ligand. And it is a protein that is expressed by osteoblasts.
So even normal osteoblasts express the RANKL.
Formation of bone. Now, RANKL actually plays an important role in osteoclast formation, function, and survival.
But it influences the function and formation of an osteoclast.
Reabsorb bone. Now, RANK, the name actually means receptor activator of nuclear factor kappa B. And RANK is actually, as its name suggests, a receptor, and it's a receptor that's located on osteoclast precursors and mature osteoclasts.
So these are present on the normal osteoclast precursors and mature osteoclasts.
Or RANKL is actually the ligand for the RANK receptor. And OPG stands for osteoprotegerin or osteoprotegerin. And this protein is actually also expressed by osteoblasts. It binds to and inhibits RANKL.
So you can clearly see RANKL stimulates osteoclastic function, whereas osteoprotegerin is an antagonist to RANKL and it's an inhibitor of osteoclastic action. So these are normal.
It inhibits RANKL.
Yes.
It is actually protective against bone loss.
So one is protective against bone loss, whereas another one is promoting bone loss by stimulating osteoclasts.
I mentioned that osteoclasts are involved in.
And let me tell you, these are all molecules which are also playing a role in the regular day-to-day bone remodeling which is taking place. They are nothing abnormal.
Activate osteoclasts. So this is the reason why OPG is protective against bone loss. So here is a brief diagram with osteoblasts and osteoclast precursors. Now, the osteoclast precursors, as we mentioned before, have the RANK receptor on their cell membrane. Now, the osteoblasts themselves will express and release the RANKL or RANK ligand protein. They also will express and release OPG or osteoprotegerin. OPG will then bind to inhibit RANKL. It's a regulator or a negative regulator of RANKL. And also interesting to point out is that estrogens like estradiol can actually act on osteoblasts to limit the release of RANKL. This becomes important during menopause with regards to osteoporosis. We'll talk about this in another lesson, but I just wanted to mention here that estradiol acts as an important regulator of RANKL release from osteoblasts. Now, if we have RANKL and it's available to bind to RANK receptors on osteoclast precursors, it initiates those osteoclast precursors to differentiate into mature osteoclasts. So mature osteoclasts actually form from multiple osteoclast precursors. So
once the osteoclasts are formed, they are going to promote
but
resorption of bone. So basically, therefore, we know that The development, progression, and biological behavior of these odontogenic lesions are going to be dictated by the osteolytic activity. So the question was, what are the molecules which bring about bone resorption? So we know that we have the rank and the rank L are two factors. These are two factors which bring about osteolysis and increased bone resorption. Whereas on the other hand, you have the osteoprotegenin, which inhibits osteoclastogenesis. So, and therefore prevents or decreases bone resorption. This is a normal balance, but so the balance between these two factors is very, very important. And you also have some other factors like the matrix metalloproteinases, MMP8, which actually again degrades bone matrix and promotes tumor progression, and some cytokines like prostaglandin E2, E3, and IL-1, which again mediate bone resorption. So these are the factors. So when you have a genetic mutation, which is going to lead to these tumors to express these factors which promote resorption. For example, the OKC, ameloblastomas, glandular odontogenic cysts, which are all very, very aggressive in their clinical course, they have a genetic mutation, which is causing an an elevated expression of the RANKL and the CATK, which are all factors which are going to promote osteoclastic activity and increased resorption and aggressiveness. Whereas a dentigerous cyst like indolent lesion, they have an elevated expression of OPG, osteoprotegenin, which explains the lower osteolytic activity and lower aggressiveness and lesser bone resorption seen with these lesions when compared to those mentioned above. So you have to understand this so that you can have targeted therapy against these factors to alter the disease pattern and change the microenvironment, get better disease control, better quality of life postoperatively, as it may avoid radical resections. So I hope there was some clarity on this, on these factors and the critical balance which needs to be maintained.
Yes, ma'am. Thank you, ma'am. This is actually a very exhaustive topic which needs a lot of discussion, but we have to keep in mind about the time also. It's already 8:30. We have to be a little fast on this, I think, ma'am. Yes. Moving on to the next question. Recent advances in the management of ameloblastoma.
So I think most of it has been covered. This is what traditionally we look at. You'll have to write the goals: complete removal, less recurrence, good function, restore function, aesthetics, minimize morbidity. Good idea to write. We have made a lot of progress over the years in terms of safety of resection. So you have to resect with 1 to 1.5 centimeter margins. And of course, in reconstruction, we made a lot of progress. Now we're going on to microvascular free flap reconstructions with iliac or fibula. And of course, virtual surgical planning with 3D printing is being used. And even the PSIs or patient-specific implants, you can write about it. But if you're really talking about advances, then you also have to add on these things, because surgery is still not the end. It's a lot of debility. It leads to a lot of morbidity. So as I said, you have to add a note if it's coming in your recent advances paper about chemotherapy, that is particularly against the platinum group of drugs and the other drugs which have been effective against the metastatic and ameloblastic carcinomas. I've already highlighted the gene therapies and those molecular therapies, targeted therapies against these biological factors, the RANKL and the OPGs which are there. Virtual surgical planning. There is a mention about the active decompression with distraction sugosteogenesis or accelerated osteogenesis, that's called the ADS, and also machine learning. Machine learning has come up. So they have come up with monograms to predict recurrence based on factors. So these are the predictors which are available. We talk about softwares. Quick note, you can add about targeted therapy. I said BRAF V600E is the mutation which is observed in 57% of the ameloblastomas, 96% of those occurring in the mandible, and the FDA has approved the vemurafenib and the dabrafenib as drugs against this mutant gene. So if you're talking about targeted therapy against mutant genes, they will act as upfront treatment with these inhibitors, will cause substantial tumor regression, particularly in the recurrent cases in the mandible and the metastatic lesions in the lungs. They have been tried. So that can be written off. And again, you have the other dysregulated genes which have been mentioned, even for the keratosis and the ameloblastomas. So tumor cells, as I said, they secrete the RANKL and the MMPs. We are still on the lookout for inhibitors against this. I don't think there are any specific inhibitors which have been which are projected in the evidence so far. But on the whole, if anybody is thinking of doing a PhD, or if you have to mention this in your recent advances paper, the scout is on to look for to inhibitors for these factors which would change the microenvironment. So targeted therapy could modulate tumor progression and disease control. That is what has to come out in your answer. So, and of course, there is this article which has come out in, I think, 2020, discussing about this ADS, that is decompression, by applying a negative pressure to a device which they have come up with, and an accelerated osteogenesis. So that is also there in the reference.
Quickly moving on to our next question. Is there a role of cryotherapy in the management of benign cyst?
So I think we are looking at no recurrence. And first of all, you will have to say the rationale for selecting a particular treatment or management strategy for a benign cyst. You want complete clearance and definitely no recurrence. And we have seen that in terms of biological behavior, all cysts are not the same. There are some factors which make it more aggressive. You, of course, are looking at least aesthetic and functional morbidity, no damage to vital structures around. So these are all the parameters when you are selecting a treatment with no additional cost, least side effects, and whether something can be used as a direct or an adjuvant treatment modality. Cryotherapy is clearly an adjuvant treatment modality. So you have to highlight, this is the mind map, historical background, principle of use, application in odontogenic cysts, what's the armamentarium, advantages, disadvantages, indications, and evidence. So it's an adjuvant therapy in these kind of lesions like OKC, where you have a high recurrence rate, where enucleation alone has not done very well because of the thin lining, poor adherence between the epithelium and stroma, locularity, size of the lesion itself, and the biological behavior itself, and the presence of daughter and satellite cysts around. So where you want to remove those organic cells which are there around the visible margins. So that's about the historical background. This, I think, will be there. So what is the principle of cryonecrosis? When you cool it down, particularly below 20 degrees, the mammalian cells will die. So when you're looking at these cryogens, like liquid nitrogen, it's minus 196 degrees Celsius is the boiling point, and the other refrigerants which have been tried are propane, butane, isobutane, where it's minus 56. But what's important is just not cooling. It is controlled freezing and slow thawing. That is very, very important. You have to write the regime there. So cryogens are those gases which are gas at normal temperature, but on bringing down the temperature and high pressure, they transform into liquid. So you have to write these physical principles. How do they bring about cryonecrosis? It is important to know that I said when you rapidly cool, you will see that the extracellular fluid, which is mainly made up of water, it goes on to form ice crystals. Once the water condenses into crystals, you will see that the electrolyte concentration will increase. So the water moves out by osmosis from the cells outside. So you will see that there is cell shrinkage. And when you bring about slow thawing for 5 minutes, the opposite of it happens. The water again is released and the cells expand and they burst out, resulting in apoptosis. So you have to write that. So as I said, when you combine cryotherapy with enucleation in these aggressive cysts, it has brought down the recurrence rate from almost 62.5% to 11.5%. And it's a good idea to compare with it with the performance of Cornoise also. So what have been the limitations of use of cryotherapy? That has to be mentioned, because liquid nitrogen itself is not available. You have to have that armamentarium, the cryoprobe. It's untested use of the other refrigerants, and it can cause reversible nerve damage. You have to protect the nerve and surrounding vital structures. It can cause wound dehiscence as well. So it cannot be used as a primary treatment. It has been used as an adjuvant with specific indications like recurrent OKCs, large complex mandibular lesions, non-compliant patients, and when conventional treatment might involve vital structures. And it's a good idea to actually compare its performance with the disadvantages of Cornoise. Cornoise also brings about some amount of necrosis of the surrounding bone, whereas the cryotherapy only destroys the organic matter of the cells and preserves the inorganic architecture of the surrounding bone, which helps in osteogenesis by its osteoconductive and inductive properties. So the bone regeneration is better when treated with cryotherapy. So you need to compare. These are some of the references which you can give.
The next question for the day is, Can 5-fluorouracil be used instead of Cornise solution?
Yeah. So when you're talking about adjunctive therapies, again, you always refer to these aggressive cysts. You'll have to talk about OKC, its biological behavior, histopathology, reasons for its recurrence. I've already highlighted that. So the recommendation in these kind of lesions is to sacrifice 1 centimeter of marginal bone around the boundaries should be removed, or rather 1 centimeter is when you do a resection, or at least 1.5 mm of bone when you are talking about chemical alternatives, so that you destroy all the organic matter which is there between the trabeculae. So you have looked at Cornise and modified Cornise, and the other drug is 5-fluorouracil. So you have to compare these 3 solutions. So it's a good idea to compare in these parameters. So what is the composition itself you have to write of the Cornise and the modified Cornise. Chloroform is not used in modified Cornise because its use is banned because it's found to be carcinogenic. FDA has banned its use. Whereas the 5-fluorouracil, uracil, you know, is a nucleoside. It's a component of DNA. And so the fluorinated derivative of that uracil is an anti-tumor drug or an anti-metabolite drug. So that has also been tried because it attacks the DNA itself and causes cell death. The historical background, so the penetration is for 1.5 millimeters around when you are using the Cornise and the modified Cornise. 5-fluorouracil, again, it has got a wide safety margin. The dose is 20 milligrams per kg. They leave it for 24 hours within the cavity, whereas the Cornise is just applied for 3 minutes because the 3 minutes itself could turn caustic and it has caused a lot of nerve damage. Evidence of success, Cornise is 2.5%. Modified Cornise, they believe, is not doing so well, 6%. By 5-fluorouracil has reported phenomenal results. It's an anti-metabolite drug. As I said, it acts on the DNA. It inhibits DNA synthesis and causes cell apoptosis. So you'll have to describe the mechanism of action, whereas Cornise is a tissue fixative. As I said, incidence of paresthesia with Cornise and modified Cornise is high, whereas it is much lower in fluorouracil, and also it preserves the surrounding bone. Sequestrum formation is less. And again, when you talk about Cornise, the shelf life is very, very less. You have to freshly prepare these solutions, whereas 5-FU is available in tubes for ready use, easy to acquire, low cost, topical application is very, very safe. So I think it's easy to use, cost-effective alternative, biocompatible, less damage to surrounding nerve, inferior alveolar nerve and soft tissue, but preliminary evidence is promising, but needs more 10-year follow-up studies. Because keratocyst itself, the occurrence incidence is low, you have to do multicentric trials to really prove the efficacy before you flag off. But of course, it holds a lot of promise. It may be the future course of treatment and a potential alternative to the others. But you need collaborative research to really flag it off as a one-stop solution.
Thank you, ma'am. Moving on to the last question of the session. Dose and duration protocol of sodium tetradecyl sulfate injection for hemangiomas.
So I'll just quickly go through this. First of all, when you talk about hemangiomas, it's a good idea to start your answer by describing these vascular anomalies. Broadly, they are classified as hemangioma, which is a vascular tumor, and vascular malformation. So you should have a good idea what is the difference between a tumor and a malformation. And again, based on the flow characteristics of Doppler, they have been classified as high flow and low flow lesions. So these are some of the classifications. You can see that hemangioma will fit into the benign tumor category, and malformations can be simple or combined based on which are the vessels which are predominantly involved in this. So as I said, they can be low flow. Low flow are the ones where capillaries. So malformation is where there is an abnormal network or a bizarre network of vessels, but the endothelium itself doesn't proliferate. There is no increased mitotic activity that is seen as in the case of hemangiomas. That's the basic fundamental difference. So low flow lesions are like capillary, venous, or lymphatic. High flow are those which are involving the arteries. I think the high pressure will explain that, and combined lesions are also there. So you have to know these classifications. Hemangiomas comes under the tumor category where you have the endothelial cell proliferation. They are not seen at birth, normally comes a little later. but they rapidly grow, but they also involute or regress over a period of time and they stabilize. Whereas a malformation is not a tumor, it is an abnormal network of blood vessels, which can either be capillaries, venous, or mixed. They are present at birth. They continue to grow along with the growth of an individual. Trauma, hormonal changes, puberty, pregnancy will cause an exacerbation in these lesions. So you are looking at low flow. So this is, you have to give the diagnostic approach or the algorithm with these things. So why it is important is where is sclerotherapy indicated? Sclerotherapy is indicated for vascular malformations, particularly the low flow malformations like the venous malformations or the lymphatic malformations. That is where sclerotherapy will work. So you have to know, you have to write about the diagnostic algorithm, clinical features, the imaging features of all these things, and what are the indications for these venous or vascular malformations. They are slow growing with exacerbation, as I said. They can produce malformations, deforming adjacent teeth, permanent aesthetic or functional damage, and their indications for use of sclerotherapy could be infection, pain, bleeding, or some kind of a functional disturbance or life-threatening disturbance like proximity to the airway, which these lesions can cause over a period of time purely because of their size. So it's a good idea to write these classifications given by Goel et al. Describing based on the size of these lesions. Surgery where you are able to completely extirpate these lesions are obviously applicable only for small size lesions. Sclerotherapy is applicable for lesions of low flow, venous or lymphatic when it involves multiple planes, much larger in size, so that you want to shrink the size of these lesions before you do a surgical extirpation. Like something like this. You can obviously see that these are all widespread lesions involving multiple planes, so causing an aesthetic and functional deformity and bleeding. So you want to reduce the blood loss. So they are safe to use, easy to administer, accepted by patients. You can see that sclerotherapy itself has done so well in these patients with good aesthetic and functional outcomes. How do they act? They mainly bring about endothelial damage. When you inject it at the site of the nidus, they destroy the endothelial cells, expose the intimal collagen, bring about a microthrombus formation. With the thrombus, there is fibrosis. So over a period of time, the whole lesion shrinks because of the fibrosis. But the bottom line is you have to hold the sclerosing agent at the site of the lesion. So if it's a high flow lesion, it will just get washed away into the systemic circulation. So you have to compare STS or sodium tetradecyl sulfate with the other sclerosing agents which have been tried. Absolute alcohol, which is the most important of these, but also extremely severe adverse effects have been there, and a whole lot of other drugs have been tried. So it's a good idea to compare and contrast these. STS was the question asked. It's available in 1 and 3%. 0.5 to 2 ml can be injected at 3 sites. Normally 3% is used. 22 or 25 gauge needle is used. And it's good to use USG and to do it under USG guidance or using digital subtraction angiography in a cath lab. You have to give a pressure dressing later on. You can repeat the injection after 3 weeks to 3 months. Now you can directly inject the liquid, or you can mix the liquid with a radio-opaque dye so that it is better seen in the cath lab on the monitor as to where your needle has reached. And one other thing which you can write about is the foam sclerotherapy, where actually you can admix air, you can admix the air, STS, as well as the iohexol, which is the radio-opaque dye. You can see that you are trying to create a foam. The objective of the whole foam is these air bubbles will actually fill up into the whatever the malformation which is there, and the foam displaces the blood and holds the sclerosing solution in place. Basically, the dwell time at the site of action will be more. So there is an increased 2 to 3-fold sclerosing power which is observed when they have used the foam, okay, in a cath lab. So you have to write these techniques and also the ratio which has been used when you combine air and the sclerosing solution and some complications. So these are some references for the answer for this question.
Thank you, ma'am. Such an information-packed answers. You have concised it in such a beautiful way that it would save days for the postgraduates to research on these topics. Thank you, ma'am, for your precious
These
time.
questions are very, very exhaustive. I think whether it is giant cell lesions or ameloblastoma or keratosis, I think they all come in a long question. So I think there is a whole lot to read, but I think we have just touched the tip of the iceberg. So students have to go into the depths of this very, very important topic.
Thanks a lot for your precious time and enlightening us with your knowledge, ma'am. Here, I also want to say thanks to the organizing committee members, especially Dr. Arun Kumar and Dr. Balaji for this opportunity for me, for their support and motivation. I also thank Dr. Kalpa for organizing it so well. Thank you.
Thank you.
Thank you, ma'am. With this, we come to the end of the first session. On behalf of Tamil Nadu AMSI, we would like to extend our heartfelt gratitude to the mentor, Dr. Srivalli Natarajan, and moderator, Dr. Triveni, for the beautiful session and their valuable contribution and time. We now move on to the next session. The mentor for the next topic is the minor oral surgery is Dr. Rekha, and the moderator is Dr. Sneha. Dr. Sneha Pednem has completed her fellowship in cleft and craniofacial surgery at CCI Zurich. She is currently a trainee in regenerative medicine at the University of Toronto, Canada, and is also pursuing her PhD at Savita Institute of Medical and Technical Sciences. Dr. Sneha has worked as a cleft surgeon on Lifeline Express, a central government project, Impact India Foundation, in collaboration with UNICEF and WHO. Dr. Sneha was awarded the Best Outgoing Student in undergraduation from MS Ramaiah Dental College, Bangalore. She was also the recipient of the award of Dr. R.S. Neelakandan Award for securing university first place in post-graduation in the field of OMFS. She was also awarded Dr. Nanda Gopal Award for securing university first place in basic sciences examination during her PG. Dr. Sneha has numerous publications to her credit and is currently working as a professor at Savita Dental College. I now request Dr. Sneha to introduce our mentor and start the program.
Good evening, everyone. It gives me immense pleasure to introduce our today's mentor, Dr. Rekha N. She is a maxillofacial surgeon and a professor in HOD at JKK Dental College, currently working at JKK Dental College. She is a PhD holder. She has completed her MNA, MS, and a diploma in national board examinations in 2005. She is a gold medalist in her post-graduation and undergraduation and has completed her post-graduation from Meenakshi Ammal Dental College in Hospital. She has numerous publications to her credit, and she is also a key member in the AMSI Association and has presented multiple guest lectures and has been a panelist for various scientific sessions. I now invite our mentor, Dr. Rekha, to take over so that we can start the session.
Thank you, Dr. Sneha, for the wonderful introduction. At the onset, I would like to thank all the organizers of the AMSI Tamil Nadu Pondicherry branch for giving me an opportunity to present in this program. I would like to mention my special thanks to Dr. Subramaniam sir, President, Dr. Arun Kumar sir, Secretary, Dr. Jimson sir, Dr. Ilavenil, Dr. Kalpa, and all the other coordinators for helping me in this program. And special thanks to you, Sneha, for helping me preparing the presentation.
Thank you, ma'am. So without delay, I think we can take the first question. That is, describe the management of root tip that is displaced into the maxillary sinus.
Okay. So whenever we are attempting a maxillary third molar or a maxillary molar extractions, especially the first molar, we know that it is very closely related to the maxillary sinus. So whenever we feel that a root tip is fractured and it is pushed into the maxillary sinus, the first thing is not to become panic. The second thing is to ascertain that we have created an oroantral communication. Okay, so the confirmation of the oral-antral communication clinically can be done by using various tests like nose blowing test, mouth mirror fog test, change in the voice resonance test, etc. And also by gentle palpation of the buccal aspect of the alveolar ridge. Once you've clinically confirmed that you've created an oral-antral communication, the second thing is to do a radiographic evaluation. The best radiograph to evaluate a displaced root tip into the maxillary sinus is by taking intraoral periapical radiograph by taking 2 radiographs, okay, using the head shake test to ascertain the position of the displaced fragments. If the position of the displaced root tip, okay, changes in the second radiograph, it means that the fragment is loose. If the position of the fragment is not changed, it means that it has got a straight line axis. So once we know that the position of the displaced root fragment, then we can resort to removal of the root tip. Okay, by a surgical method, you can enlarge the alveolar socket and try to irrigate the socket, and then we can also use a suction, a high volume suction to remove the roots, or by using a gauze method or removal of the piece by a fiber optic aids. If you're not able to do an intra-alveolar removal of the displaced root tips, then we can resort to Calvin look approach. So going on to the same protocol in detail. So first is to check the position of the root and the integrity of the sinus lining. If the sinus lining is intact, then the root can be gently teased out from the maxillary sinus. If the membrane is pierced, then the position can be checked with, as already mentioned, with 2 periapical radiographs, or with the help of a PG, or by a lateral oblique view, or maxillary occlusal view, or in few cases with the help of a CT scan or a CBCT. Going on, how do you manage a displace where you have now ascertained the displacement of the root tip into the maxillary sinus by a proper clinical examination? You have now confirmed it with a radiographic examination also. Now the next step is to manage the removal of the root tip from the maxillary sinus. The first method or the mode is to defer the treatment or therapeutic abstention in cases if you feel that there is an absence of clinical or radiographic symptoms, or in the presence of an healthy sinus, or if the foreign body is without any acute initial infection, or if the root fragment is smaller than the ostium. Okay, then if you resort to removal of the root, then there are 2 ways of removing it. One is by an alveolar crystal approach, where you enlarge the extraction socket, and then you try to remove the root out of the socket. The second method is to remove by using the Calvin-Luke approach, where you create a lateral bony window in the apex of the canine region to retrieve the root out of the maxillary sinus. The third method is to use an endoscopic sinus surgery to remove the displaced root fragments. The alveolar crystal approach allows for the immediate removal of the displaced root through an orantal opening, while the Calvin-Luke consists of removing the foreign body through the canine fossa. And though alveolar socket approach is the most preferred approach, it has its limitations that we are widening the orantal communication. So Calvin-Luke, there are some people who say, there are some articles which says that Calvin-Luke approach is much preferred and it is the gold standard for this kind of maxillary sinus surgery. But there are certain disadvantages of Calvin-Luke approach also, such as facial pain, hyposthesia due to injury to the infraorbital nerve, or anesthesia or paresthesia due to injury to the anterior superior alveolar nerve. The next is endoscopic sinus surgery by nasal route for the removal of the root in the maxillary sinus. It is based on the use of optic along with computed imaging, CT imaging. Less invasive, less traumatic. It also avoids causing damage, nerve damage, preserves the adjacent roots as well as the alveolar. Not only it removes the root, but also it preserves the mucociliary integrity and function, and it also drains the clogged maxillary ostium by recreating the optical permeability. So endoscopy is now increasingly used for both by a nasal approach as well as by a approach, or by a combination between the transoral and transnasal approaches. So this is a CT scan which shows that there is a root tip which is displaced into the maxillary antrum. And this is an endoscopy view of a displaced root tip into the maxillary antrum. Dr. Sneha?
Ma'am, the next question for today is, what are the absolute and relative contraindications for extraction?
This is the most commonly asked viva question in any undergraduate or postgraduate program. So let us go on in detail about this question. The absolute contraindications for extraction B, you can classify it into two ways. Okay, contraindications. One is an absolute contraindication, which means that under no condition that the tooth will be extracted in such cases. Okay, whereas a relative contraindication means you can do extraction weighing the risks and benefits. So it is when you, in your choice, after controlling the infection or the inflammation or the condition, after controlling the condition, you will be able to proceed with extraction. So the most important absolute systemic contraindications being brittle uncontrolled diabetes. Okay, because why this is absolutely contraindicated? Because the stress of the surgery can result in metabolic perturbation, which causes changes in the glucose homeostasis, which results in persistent hyperglycemia. We know that whenever there is an increase in the blood sugar levels, it can precipitate diabetic crisis, it can lead to endothelial dysfunction, it can result in postoperative infections and impaired wound healing, as well as it can result in cerebral ischemia. Nevertheless, locally it can produce incidence of dry socket also, and the patients will be more prone to infections because of the higher glucose levels in the brain. It can also result in atherosclerosis. Then the second condition where it is absolutely contraindicated is a severe renal disease because of the alteration in the calcium and phosphate metabolism, which can result in bone demineralization, resulting in decreased trabeculation, which can lead to jaw fracture and abnormal healing after extractions. It can also increase the bleeding tendencies because of the presence of renal anemia and alteration in platelet aggregation. And because of the heparin, which is an anticoagulant which is used during dialysis, it can produce ecchymosis, petechiae, and hemorrhage. And it can also make the patient more susceptible to infections, especially in patients with kidney transplants because of immunosuppressive therapy. The third contraindication being uncontrolled leukemia and lymphoma, where there is a tendency to increased bleeding. So this intraoral bleeding can result in petechiae, ecchymosis, or in the form of an hematoma. And there is again an increased risk of infection in these patients. And the patients are also at a risk of developing osteoradionecrosis. The next one is a severe uncontrolled cardiac diseases, where the patients can there is an increase in the likelihood of cardiac arrhythmias in such patients, and we know that whenever there is a cardiac patient, they are mostly on anticoagulants. So there is increase in the bleeding tendencies in such patients, and use of lignocaine with adrenaline in some cardiac patients can induce cardiac arrhythmias, and it can even result in collapse of the patient. Again, in case of recent myocardial infections, within 6 months, usually they say now it is like 3 months. So 3 to 6 months period immediately following myocardial infection, it can be an absolute contraindication. And again, in case of toxic goiter, which can precipitate thyroid crisis and result in cardiac embarrassment and heart failure. Then local contraindications, like local absolute contraindications being teeth which is adjacent or located in a malignant tumor, which can result in dissemination of the malignant cells and hasten the metastatic potential, and it can also bleed very easily. And teeth which are in close contact with the vascular lesions like AV malformations and hemangiomas, which can result in dramatic bleeding. Relative contraindications for extraction being regular systemic contraindications being the pregnancy, the first and third trimester of pregnancy. First trimester of pregnancy because it can damage, it can produce vulnerability of the fetus, and it can interfere with organogenesis of the fetus. Third trimester of pregnancy because it can result in premature delivery. And severe bleeding disorders and polycythemia vera, which can result in severe bleeding tendencies. Patients on anticoagulant therapy like heparin, warfarin, and even on antiplatelet agents like aspirin and clopidogrel. For such patients, it is only a relative contraindication. We can do extractions if the INR is within the range of 2 to 4 with proper local hemostasis. This is important. Proper local hemostasis is very, very important. Again, patients on medications like corticosteroids and immunosuppressive therapy, we know that when the patient is on long-term corticosteroids, it can precipitate adrenal crisis, and it can also make the patient more vulnerable to postoperative infections also. So we have to supplement the patient with double the dose of steroids, corticosteroids. Cortisone 50 to 100 milligrams, cortisone orally 2 hours preoperatively, or 100 mg of hydrocortisone IV 12 hours postoperatively. And in cases of cirrhosis of the liver, again, cirrhosis of the liver can result in decrease in the clotting factors, which can produce abnormal results in platelet time, prothrombin time, and the INR and the partial thromboplastin time. And it can also make the patient more susceptible to infections. Jaundice, again, because of the decrease in the clotting factors, which can result in prolonged hemorrhage. In case of rheumatic heart disease, patients have a danger of contracting infective endocarditis. So such patients have to be put on prophylactic regimes before undertaking extractions, and nephritis and syphilis. So local relative contraindications include radiotherapy. Okay, patients who have underwent recent radiotherapy for oral cancer or in the head and neck region, because they are more prone to develop osteoradionecrosis. Patients with severe pericoronitis. We know that patients with pericoronitis are indications for removal of mandibular third molars. At the same time, if there is a severe pericoronitis, it is a relative contraindication for removal of mandibular impacted third molars. Also in cases of acute maxillary sinusitis and acute gingival inflammations, any acute condition, acute infection is a contraindication for the removal of tooth.
The next question is about what is lingual split bone technique for removal of third molars?
This is a topic which has been discussed for a longer period of time, and which is not usually understood by students, because it is not very regularly practiced. Okay, so we'll just see this. The first one is to when we have a buccal cortical plate, the first step is to place a vertical bony cut. Okay, 5 millimeter bony cut. Okay, here you can see here a 5 millimeter bony cut, which is placed on the distal aspect of the mandibular second molar. Okay, with the help of a 3 millimeter chisel. The second step is to place again a vertical second bony cut, which is 4 millimeter from the distobuccal surface of the mandibular second molar. And then next step is to put a horizontal cut here, so that this buccal fragment of the bone will be removed. The next step is to angulate the chisel at 45 degrees to the in the height of the lingual crest. Okay, in relation to the mandibular third molar, and then this angulation of the chisel should be in the direction of the opposite side mandibular second premolar. The direction of the chisel should be in the direction of the contralateral side mandibular second premolar. And then once we do that, we have to remove the intermediate bone between the buccal and the lingual cuts, and then the tooth can be elevated by using a straight elevator. Tooth can be elevated by using a straight elevator. The lingual cortical plate will splay, and then it will yield in the removal of the tooth. Once it is done, the fractured lingual cortical plate, the bit of the lingual cortical plate which is fractured, is removed, and the wound toilet is ensured, and the toilet wound is cleaned, and then suturing is done. We can just see this. This is a small video which I've seen. They have done a dummy model presentation to demonstrate lingual split technique. Okay. So first one is to make a vertical cut. You can see that the vertical cut is being made here. Okay, once it is done, then the horizontal cut is done.
Ma'am, are you showing a video, ma'am?
Yeah, you're not able to see that?
No, ma'am. Sneha, ma'am, can you see, ma'am, video?
No, ma'am. Ma'am, your video is not seen.
Okay. Okay, we'll skip that. So this is a we do a lingual split technique. So we can see here that this is incision. The first is to make a vertical stop cut here. Okay, just behind the mandibular second molar. Okay, with the help of a 5 millimeter. The length of this will be 5 millimeter stop cut with the help of a 3 millimeter chisel. The second step is to make a horizontal. This is a modified lingual split technique. Second step is to make a horizontal bone cut. Okay, from the depth of the vertical cut to the alveolar crest region. Okay, second step is to make a horizontal bone cut. The third step is to do a split of the distolingual split bone. Okay, this angulation of the chisel should be in the direction of the contralateral mandibular second molar, and then removal of the bone between the buccal and the distolingual bone. This is removed, and then elevation of the tooth is done, and removal of the distolingual bone, the fractured lingual cortical plate. The distolingual part of the bone has been removed, and then suturing is done.
Ma'am, there's a small question that has come up. If we remove the lingual cortical plate when we do the lingual split technique, or is it left
Sorry?
in situ? Do we remove the lingual cortical plate, or is it left in situ and then suture?
If the lingual cortical plate is attached to the mucoperiosteum, we can place it in situ and suture it. If it is like without the periosteal attachment, then it can well be removed, and then its suturing is done.
Moving on to the next question. The question is, what is the relationship of the lingual nerve to the lingual cortex of the mandibular third molar, and what are the surgical implications of this relationship?
Okay. Whenever we do a mandibular third molar surgery, the lingual nerve is the most dreaded component, because the lingual nerve runs in the submucosal region in relation to the mandibular third molars, in close relationship with the mandibular third molars. So according to the Journal of Oral and Maxillofacial Research 2013, the distance of the lingual nerve from the mandibular third molar, this is the lingual nerve, this is a mandibular third molar socket. So distance of the horizontal distance of the lingual nerve from the mandibular third molar socket was found to be 4.4 millimeter, whereas the vertical distance of the lingual nerve from the lingual alveolar rim of the third molar socket on an average was found to be 16.8 millimeter. There are various journals which quote, various articles which quote various values, but mostly it is found to be between around this horizontally around 4 to 6 millimeters, and vertically it is around from a range of 8 to 16 millimeter. So we can see that this is the lingual nerve which runs close to the mandibular third molar. So we can see that this point E is the closest point where the lingual nerve runs close to the mandibular third molar region. So this distance they've estimated to be 4.4 millimeter, whereas the vertical height is estimated to be 16.8 millimeters. And the implications being the whenever we do a mandibular third molar impaction surgery, or during BSSO or any surgeries which are involving in that region, the lingual nerve injury is more prone to occur. So we should, there are always controversies regarding whether we should use a periosteal elevator for lingual flap protection or not, because there are some who advocate that whenever we use a periosteal elevator for protecting the lingual flap, that can itself produce compression of the lingual nerve, and it can produce transient neuropraxia of the lingual nerve. There are many others who advocate that whenever we do a bone cutting and cutting of the distolingual spur, there has to be the lingual nerve has to be protected by the use of a periosteal elevator. So anatomy is a proper surgical anatomy of this region is very important to ensure protection of the lingual nerve and prevention of lingual nerve injury.
Sneha ma'am, you're muted, ma'am. Sneha ma'am?
Yeah, the next question, ma'am. How do you prevent maxillary tuberosity fractures? And if it fractures, how do you manage it during third molar extraction, maxillary third molar extraction?
Yes, Dr. Sneha. Before going on to the prevention and management of maxillary tuberosity fractures during removal of the maxillary third molars, let us now find out the etiological factors. Because when we know the causes why it fractures, then it will be very easy to prevent and manage a maxillary tuberosity fracture. The most important etiological factors which are listed in the literature are a large maxillary sinus with thin walls, or extension of the sinus extension into the maxillary tuberosity region, or large projection lens of the root apices into the sinus cavity. So in such conditions, what do? We do a tooth sectioning and removal of the roots one by one at a time would be the most operative technique in these cases. The second cause would be early loss of maxillary tooth. We know that whenever there is an early loss of the maxillary first molars, it produces pneumatization of the maxillary antrum. So what happens is the maxillary antral lining comes very close with the to the level of the alveolar crest. So that results in whenever we attempt an extraction, it can easily fracture the maxillary tuberosity in that region. Okay, and third cause can be the maxillary third molar can be unerupted and can be even fused to the second molar, creating a source of weakness in the tuberosity region. Or in cases of isolated maxillary third molars or teeth with large divergent roots, teeth with abnormal number of roots or curved roots, or those with dental anomalies such as tooth fusion or over eruption, are those teeth which are ankylosed, hypercementosed, or the ones with chronic periapical infection, or the ones with periapical cyst. All these things can predispose to maxillary tuberosity fractures. Okay, needless to say that if there is a excessive force during luxation of the maxillary third molars, that can also result in maxillary tuberosity fracture. So now, knowing the causes, okay, how will you prevent a maxillary tuberosity fracture? The first one is by using a proper preoperative assessment, including a detailed radiograph to know any anatomical variations or potential risk factors that may increase the likelihood of a tuberosity fracture. The second one is by use of a proper surgical technique, including adequate flap reflection, a controlled bone removal, and minimal trauma to the soft tissues or to the adjacent teeth and adjacent surrounding bony structures. So by proper preoperative assessment includes a proper pre-extraction radiograph, which may reveal a presence of a large antrum. So in such cases, as already mentioned, sectioning of the tooth and removal of the root one by one would be the most operative technique to avoid a tuberosity fracture. With periapical radiographs, the structures can be viewed more easily and before performing any surgical procedure. But when we take OPGs, the problem with OPGs is that the root projection length into the maxillary sinus cavity is estimated to be 2.1 times larger than the actual root protrusion length into the sinus in CT scans. So OPGs are not recommended to assess maxillary tuberosity area. Okay, so ideal preferred ones are the IOPAs, and in some extreme conditions or rare situations would warrant a need of a CT scan or cone beam CT scan whenever there is a requirement. Okay, so once we know that the maxillary tuberosity has fractured, okay, we have to stop the procedure before any inadvertent laceration of the adjacent soft tissue occurs, and then determine the extent of the fracture by palpating the mobile fragment. Okay, if there are two ways of managing it, depending upon whether the fractured tuberosity is small or large. If the fractured tuberosity is small, with only one teeth, or if the tooth is infected or symptomatic at the moment of fracture, then the fracture should not be left in situ. And in such cases, then the tooth has to be removed along with the fractured attached bony tuberosity. If the bony fragment is large enough, then four procedures can be done. Okay, the first one is that the extraction should be stopped and surgical removal of the tooth can be performed by means of root sectioning. The second way of doing it is to detach the fractured tuberosity from the roots. Slowly try to tease off the fractured bony tuberosity from the roots, so that any remaining periosteum which is attached to the maxillary tuberosity will make it more viable, will enable it to be maintained more viable, and the vascularized bone can then be compressed into the sinus communication area. Third one is whenever there is an adequate periosteal attachment which has been maintained, then we can stabilize the fractured bony parts by using a rigid fixation technique for 4 to 6 weeks, and then later try to surgically remove the tooth without the use of forceps. The fourth technique is if the large fragment is already detached from the maxilla, then if you feel that the segment cannot be properly repositioned and when primary stabilization cannot be achieved, then we can remove the fractured large bony tumorosity, and the soft tissue attachments should be properly removed from the hard tissue so that we have remaining soft tissue which is left to suture that particular region.
Moving on to the next question, ma'am. Post-operative instructions and the scientific reasons behind these instructions.
Okay, so this is most commonly you are not supposed to, you have to instruct the patient not to rinse the mouth on the particular day because we know that it will result in dislodgement of the blood clot if fibrin stabilization has not occurred. Do not take anything hot because heat produces vasodilatation, so that may increase the tendency for bleeding from that area, and do not drink alcohol for the same reason because alcohol also produces vasodilatation which can increase the local blood vascularity and which can result in bleeding tendencies. Do not smoke or do not use tobacco products for at least 24 hours because smoking produces a negative suction which can result in dislodgement of the blood clot and possibly result in dry socket. Do not chew food for 4 hours or hot foods for 24 hours because it may disturb the clot formation, and patient can even produce self-harm, biting of the lips or the tongue till the anesthetic efficacy wears away. And do not carry out any physical activity because it can increase the blood pressure and rather contribute to increased bleeding tendencies. And what the patient is advised to take, patient can take lukewarm drinks because it helps in, it prevents clot removal by washing out the socket. Ask the patient to bite on clean gauze for 10 minutes if the area bleeds, and ask the patient to sit upright in a dental chair so that it decreases bleeding tendencies, and rinse the mouth gently with hot salt, warm saline washes or with chlorhexidine solutions to keep the socket and prevent it from getting infected, and clean the teeth as normal, but avoid brushing in the area of extraction because they might interfere with the clot, they might dislodge the blood clot, or they can induce bleeding tendencies in the extraction socket area. So this is which is given up in a much detailed way.
Moving on to the next question. If the patient presents with space infection secondary to an infected third molar, should we administer IV antibiotics first and then proceed to the removal of source of infection, or vice versa? That is, remove the source of infection and followed by antibiotic therapy. How do we practice in a clinical scenario?
So the basic principles of therapy whenever we have an odontogenic space infection is first is to determine the severity of infection. Okay, supposingly if we feel that the swelling is large, okay, it is like extending into the neck. Okay, in such cases, we have to do an emergency management. First, we have to find out whether it is going to compromise your airway or not. So such things have to be assessed. The second principle is to evaluate the state of patient's post-defense mechanisms, whether he is immunocompromised or whether his immune status is normal. Third principle is to determine whether the treatment is to be rendered by a general physician or by a oral and maxillofacial surgeon. And the fourth principle is to treat the infection surgically, followed by medical support to the patient. And the sixth principle is to choose and prescribe appropriate antibiotic therapy and also administer the antibiotics in a proper way, and followed by post-operative evaluation. So whenever we go to the principles of antibiotic therapy, use empiric antibiotic therapy, use narrow spectrum of drug, antibiotic with the least toxicity, and especially bactericidal and not bacteriostatic. So if the host immune system is good, then remove the source of infection, followed by IND if needed, and along with empirical antibiotics. And if the patient is overly hydrated or if the airway is compromised, then the patients have to be admitted and patient have to be managed. If the immune system is on the other hand compromised, then patient have to be admitted first and adequate nutrition and hydration support for the patient have to be given, followed by IV empirical antibiotics. Then the immune compromise, whatever is the condition which is producing the immune compromise, have to be corrected, remove the source of infection, and followed by, along with IND if needed, followed by culture guided antibiotics and admission whenever there is a problem with the hydration or if the airway is compromised.
That sums up. Yeah. Okay.
Yeah. So whenever the patient has an odontogenic infection, so presence of severe signs of severity, if there is a signs of severity like dyspnea, stridor, dysphagia, odontophagia, trismus or crepitus, then patient have to be immediately hospitalized with IV antibiotics and CT scan, contrast enhanced CT scan and surgical drainage of the abscess and or the deep neck infection if it is necessary. If there are no signs of severity, check if it is a mandibular odontogenic infection, because mandibular space infections can progress to Ludwig's angina, which can potentially create a threat for the airway. So yes, if you feel that it is severe, then again the patient have to be hospitalized. If it is not compromising with the airway, then patient can be given antibiotics, symptomatic treatment, and followed by extraction and IND.
Thank you, ma'am. That was a lot of discussion that has been covered in brief, because mild surgery is too extensive. It's the primary breadwinner for all of us. And I think the PGs actually really need to go back and read a lot in mild surgery, because that is what is very important from chairside fiber perspective. Thank you, ma'am. That was really enlightening. Thank you, Kalpa. Thank you, team, for giving us this wonderful opportunity to interact with the postgraduates. Over to Dr. Kalpa.
Thank you so much, ma'am. Now we come to the end of this beautiful session. This was a very important topic, and both the topics were covered in brief, but very important important topics were discussed, and the answers were definitely something very new, and the information that was given by the mentors and the moderators were definitely added. I'm sure it would have added to the knowledge of the postgraduates and will make them more confident to answer difficult questions in their Viva. So now, on behalf of Tamil Nadu AMSI, we would like to extend our heartfelt gratitude to the mentor, Dr. Rekha, and moderator, Dr. Sneha, for the